bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAPHC's programs and activities. Everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. Today's webinar is titled Caregiving, FASD, and Alcohol, caring about FASD prevention. As I mentioned, we've got a great panel today, and this is all in recognition of International FASD Awareness Day, which is today, September 9th. For those of you who might be listening later on the recording, September 9th is FASD Awareness Day. It's a great opportunity for us at CAPHC to once again partner with the Public Health Agency of Canada on the important topic of fetal alcohol spectrum disorder. Over the past few years, we've had a great partnership that has allowed us, partnership with Public Health Agency of Canada, that has allowed us to put together a toolkit of screening tools for FASD, and to bring a lot of FASD content on a wide variety of topics, bringing research and interventions and all sorts of information about FASD to our webinar series, to our conferences, and everything else. So it's all that information about our work with Public Health Agency in relation to fetal alcohol spectrum disorder is available on the Knowledge Exchange Network. So use the search functionality to find all that great information on there. So it's my pleasure now to just hear a few from one of our colleagues, Holly McKay, who's a Senior Policy Analyst at the Public Health Agency of Canada. So, Holly, over to you.
Okay, thanks. I just wanted to welcome everybody from here in Ottawa at the Public Health Agency. We're very happy to be bringing you this webinar today, and we look forward to being in touch with people over this afterwards, and enjoy the morning. I'll turn it back to you, Doug.
All right. Thank you, Holly. So now it's my pleasure to introduce our panel. First, I'd like to mention we also have my co-host, who often joins me on these topics related to fetal alcohol spectrum disorder and children's rehab services, etc. We have Dr. Gail Andrew from the Glen Rose Rehabilitation Hospital in Edmonton. So welcome, Dr. Andrew.
Thanks, Doug. I'm glad to be here to share International FASD Day with a broad audience.
And our speakers today, we have Dr. Dorothy Badry and Dr. Deborah Goodman, who will be bringing us some information on the Caregivers curriculum that they were the creators of. Dr. Badry is an associate professor in the Faculty of Social Work at the University of Calgary. Her interests and area of expertise primarily focus on fetal alcohol spectrum disorder, birth mothers and families of children with FASD, substance abuse, etc. So some great expertise there. And joining her is Dr. Deborah Goodman, who is the Manager of Research and Program Evaluation at the Child Welfare Institute of the Children's Aid Society of Toronto. She's also an assistant professor at the Factor Inwentash Faculty of Social Work at the University of Toronto. And then following them, we'll be hearing from Dowsett Johnston. It's a real pleasure to have Anne joining us. She's an award-winning journalist and best-selling author of Drink, the Intimate Relationship Between Women and Alcohol. So she's going to be giving us some great talk of her experiences and some great information from her book. All right, so it's now my pleasure to hand the virtual podium over to Dr. Dorothy Badry. Over to you, Dorothy.
Good morning, everybody from Alberta, Calgary, Alberta. It's nice to be here this morning. We're very honored to be able to share the Caregiver curriculum on FASD to this audience, and Dr. Deb Goodman and myself have been part of a team for about 5 years now that have continued this work. And I want to just start by saying that caregiving is heart work. It's work of the heart. Caring is such an important function in our society, especially when we talk about vulnerable children and families. So it's really important that we recognize that caregiving is hard work. It's hard work sometimes too, but it's also hard work. We just want to briefly mention that this curriculum is not meant to replace any good medical information that you could get or seeking any kind of diagnosis. So we'll just leave that really briefly. Just setting the stage, we know that FASD is a major public health issue, and particularly in child protection jurisdictions. And, you know, we looked at that in the 3 provinces of Alberta, Manitoba, and Ontario. Out of that work, we did an inventory on FASD across Canada, across all the different services. We did a prevalence study, and we created the website FASDchildwelfare.ca to recognize that this is a specialized population within the child care or child welfare system. So if we look at what a caregiver is, and sometimes I just like to go to the dictionary to look for words. It's interesting because caregiver emerged only in 1966, and the term guardian has been in the literature since the 15th century. So it's important to recognize that the work we're doing is more of a reflection of modern times. And we have parents as caregivers, we have grandparents, we have multiple family members that get involved, and we have public care. So that's an issue certainly for children with FASD and something that we need to recognize. So why develop the caregiver curriculum on FASD? We know that many people caring for children with FASD, no matter where they are, don't necessarily have knowledge or training about FASD. And I believe very firmly that training and knowledge on FASD reduces stigma around the needs of children with FASD. So we need all the information that we can get to provide what we would call FASD-informed care. The website was developed to help broaden and spread the message that FASD is a disability, and of course it's International FASD Day, and we really believe strongly that if we look at FASD from a disability model, that we have a firm foundation to provide support. Our other goal is to mobilize knowledge on FASD and to acknowledge that the best care is provided by training, education, and FASD-informed practice. So when you develop a curriculum, you ask, who's it for? Well, in this case, the curriculum is for the children. We know there's children and adolescents and adults with FASD as well, but if we have an opportunity to involve ourselves in early intervention with children and families, that supports prevention. But we did this work as a labor of love really for the children. And I myself worked in child protection for many years, 16 years, and so I certainly encountered FASD within that system and met many children and families affected by substance use. So what's our goal? We want to provide solid practical knowledge to you. We want to appreciate that FASD is really a complex disability, and even after a diagnosis, children, it's important because you can support children, but you also need the practical tools of living day to day. So we support FASD-informed care. So the curriculum is a free resource accessible to anybody. We did it as a set of modules, and I'm just going to go right now to the website to give you a little bit of information. We have had a translation, but we have more work to do in terms of moving that translation into the actual website. So I'm just pulling up the link here to the website, and I'm just going to quickly show you the website, FASDchildwelfare.ca. We decided to call it FASDchildwelfare.ca because we recognized how many children are in care with FASD. And so when you go to the website here, we've got the home, community, resources, and learning. So when you click on learning in the top menu button, you will see the caregiver curriculum on FASD. And just to quickly point out, they are in PowerPoints and PDFs, which make it universally accessible, and we talked with our librarians around that. And we also have the download for the PowerPoint viewer or the Adobe viewer. So I'm just going to give you one sample because we have limited time, and part of what you can do when this webinar is complete is to explore explore this yourselves. Just quickly, the modules are the impact of FASD, understanding FASD as a disability for children in care, and that means children in care anywhere. Reframing FASD, caring for the caregivers, compassion fatigue, FASD and behavior, behavioral concerns, understanding dysmaturity, which is a major issue with children with FASD, adjusting and adapting expectations, which really makes a difference in care, practical approaches to behavior management. In Module 5, it's a special topic where we highlight grief and loss, and we really want to acknowledge Jan Lutke here from BC, with the Canada FASD Research Network, who really spearheaded a lot of the conferences at UBC, and so she supported this module. So we called on experts, and the interprofessional matrix on FASD really provides a place where you can look at what all the allied professions do with FASD. It's not an exhaustive list, but at least provides a bit of information to a parent looking up what does an occupational therapist do. And so these are tools that we've wanted to give to caregivers to recognize that there is a lot of needs for children with FASD. There's high needs. So that's basically the curriculum. We haven't been very active with the blogs, just so you know. And there's the website, so you can look at that, you can explore that, and we invite you to do that. So I'm putting the slides back up here, and it's very accessible, it's very user-friendly. The other thing it does is it reframes FASD from a strengths-based perspective and recognizes learning styles. So we look at some different theories, like Gardner's theory of multiple intelligences, that tells us that, you know, kids might not be smart in one thing, but they might be smart in other things. And that may not even be the best word, but the point is that everybody has strengths. And so if we look at alternative ways of learning, we can invite people to learn, children to learn from a strengths-based position that recognizes their own learning style. I'll just skip that. This is again a view of the website, which I'll just go right over because we saw it. Looking at some of the common concerns for caring for children with FASD, behavioral challenges, and that is often the key driver for intervention. People just say, I need help with caring for this child. How can you help me? Memory, sleep. Sleep is a huge problem. Transitions, time management, money management. Being taken advantage of in a lot of these areas are some of the vulnerabilities. Friendships, adolescence is a time of transition with many things going on, and there's a lot of vulnerabilities, including peer influences. So I would suggest that people with FASD are as they may be prone to vulnerabilities with negative behavior and negative influences, but I also believe that they're prone to the effects of good influences. And I just want to highlight that because I think it's really important that we surround children with FASD with care and in somewhat of a protective, facilitated way. So this is the interprofessional matrix of care, so you can just click on those buttons. There's easy navigation buttons, the blue arrows there to go through everything. We've divided the professionals into health, I can't even read the yellow there, community living, behavior supports, family caregiver supports, and other professionals. So we just invite you to look at that, to explore that. It's not an exhaustive list, but at least provides some basic information. So what we want to say, it's important to help people who work with children with FASD as caregivers to come from a place of some knowledge and some solid foundation. So this curriculum is a beginning place. We recognize the complexity. We encourage people to use the curriculum. It can be downloaded. It can be adapted. So I envision that perhaps we have, a training in a small community where people can use this as a resource. You can add your own things to it. So these are universally accessible. and we invite you to use it. And it's available for you to adapt. And just the good news for us is that we've had 35,000 credible hits and over 6,000 downloads of the curriculum. As I said, it's a free resource. It's about knowledge and learning, so there's no funds paid for this resource. It's just available to you. And so this, we're hoping, would be one way to support the care and the needs of children with FASD, but not just the care and needs of children with FASD, but the care and needs of those doing that work from their heart and caring for children that are very vulnerable, but can also thrive with supportive environments. And this is we did a focus group with foster parents, actually, who had received some FASD training in Alberta, and this was some of the words that they identified. So it really, understanding, confidence, competence, environment, learning, and lifelong, that's a key word as well. This is a lifelong disability. It goes across the lifespan, so it's very critical that we understand that decisions made and care structures established for children at an early age can have long-term influences. Decisions made in early intervention can really influence the lifelong trajectory of the person with FASD. So, the children with FASD need, or caregivers need, respite, early intervention wherever possible, access to diagnostic resources, disability funding, educational support, training, behavioral support, access to community programs, access to other professionals to engage in planning for the child, legal help where needed, and financial resources. And so we recognize that the job of caregiving is not easy when it comes to children with FASD. We know we will face many challenges, but with support, children and caregivers and families can thrive. Thank you.
Just my chance to remind everyone that if you do have any questions for Dorothy or for Deborah, Dr. Deborah Goodman, also with us, not doing the presentation, but certainly here to answer any questions that you have, please do type them into the question box, and we will get to those perhaps following our next speaker. So next up we have Ann Dowsett Johnston, who's as I mentioned, an award-winning writer and editor of author of the book Drink. So we're now going to hear from Ann Dowsett Johnston. Over to you, Ann.
Good morning. I'm speaking here from Toronto, and I'm thrilled to be able to share some thoughts on this really critical issue. My book Drink talks about, amongst other things, my own history with drinking and the fact that in my 50s I got into trouble with alcohol and indeed became an alcoholic and had to change my life. It's a very, very difficult thing to quit drinking, very challenging, and the reason it is that we live in an alcogenic culture. Walk into any social event and the first question you'll be asked is red or white. We all know that, and it's a culture where if you know your wines, you're sophisticated, and if you know your vodkas, you're young and hip, and if you know your coolers, you're young and female. We all know this. What we've seen in the last, I'll say since about 1995, 1996, is a very curious pinking of the market, what I call in the book the pinking of the market, which is the alcohol industry's focusing on the female gender. And that was done, interestingly, because there was an understanding that men were functioning well in terms of consuming alcohol. I'll put quotation marks around well. And women were lagging behind. And so the spirits industry, which was losing all its Johnny Walker Red drinkers, were dying out, did market segmentation and looked around the world and realized that a whole gender was underperforming, and that gender was female. And so we saw the birth of the cooler, those sweet, pre-packaged flavored drinks aimed at young women, chick beer, starter drinks to steer young women away from beer and towards alcohol, and the experiment paid off. And so now we have a very curious and I think tragic situation where women in some cultures are outperforming men. I'll give you the example of Ireland, where I was recently, where women are drinking far more, consuming far more alcohol than men are, and are drinking twice what they did in the 1960s. And what they're seeing in the UK have seen in the last decade, is a tripling of liver disease. And for young women who are in their 20s, dying of liver disease, which has classically been an old man's illness. So we have a really tragic situation, and I would say a very troubling situation in Canada, which is that the steepest increase in terms of risky drinking, binge drinking, is for the age group between 24 and 36, and this is troubling because, and I should say steepest next to the teenage, the one just before them, but this is extremely troubling because this is the group that gives birth to 60% of Canadian babies. And so we need to start having a serious open dialogue of connect the dots between what it means to have an extreme drinking culture, a culture that is really changing, where people are drinking, to use Sharon Wilsnack, the great researcher's term, drinking efficiently. And that means you pre-drink. You don't mix your drinks with other substances. You don't pace yourself. You're drinking to get drunk. And a few years ago, we had really compelling evidence emerge, as most of you would know, on the connection between breast cancer and alcohol consumption for women. 15% of breast cancer cases can be linked to alcohol consumption. And my argument is that people are not aware of that. And most extremely and most troubling, they're not aware, as Jan Lutke would say, and to reference her as Dorothy just did, they're not aware that FASD is something that is pertinent to all Canadians, pertinent and important, and needs to be discussed and needs to be thought of. So if we go back to the population of 24 to 36, we all know how many pregnancies are unplanned, and we really got a troubling situation. I'm going to quote in my book from Jan Lutke's amazing comment, and her comment is, she being so well seasoned in the disability, she's a Vancouver mother who has adopted 25 children with FASD, 16 with the diagnosis, and 10 of whom still live with her. So, sorry, 16 with the diagnosis. So she's very well seasoned and a huge advocate, and her quote is this: if you're white, you have ADHD. If you're not, you're FASD. If you look at an Aboriginal kid, it's the first thing people think of. If you look at a Caucasian kid, it's the last thing people think of, as if skin color protects you from the effects of alcohol. We think this disability only affects the disenfranchised or the poor. This is not an us or them issue, it's an us issue. And so my point today is that I really want to reference is this is an us issue. We have been, a group of us in Canada, fighting very, very hard against the stigma against addiction. I'm a founding member of a group called Faces and Voices of Recovery, trying to address the stigma around addiction, much as many have done around the stigma around mental health, and so successfully in this country. But we need to talk about the stigma around FASD, and we need to talk about, I think, the othering, the shaming and blaming of birth mothers, of those with FASD, and talk about addiction and the resulting effects, including FASD, in a much more compassionate, much more supportive, much more thoughtful way than we have been. The ignorance, especially around the educated and the professional population on this subject, especially with reference to what I was just speaking of in terms of the othering, the shaming and blaming is actually enormous. And I think one of the most eloquent proofs of that is 3 studies that took place, one in Australia, one in the US, and one in England, of pregnant women who were educated on the facts of FASD and were drinking when they were pregnant, and when they found out they were pregnant, the more educated and the older women did not slow down. It's as if they believed that there would be a protection for them. And we know that FASD is color and circumstances are not relevant. Alcohol is relevant. So I see us as in a very, very new frontier of speaking about this subject in, as I say, an alcogenic society, a society where we do other those who are in trouble with addiction, and we definitely other those who have FASD in their circumstances. And so I applaud those who have put this dialogue together today. I applaud those who have worked so hard in BC to put together the remarkable international conferences that have taken place. I applaud the opportunity to start speaking openly about what it means to be addicted, what it means to be a birth mother, what it means to be a birth mother and who is has already punished themselves and does not need more punishment from society, but rather needs support and community and assistance and help. We are just beginning to approach the notion of proper diagnosis, and we do not have the capacity in this country that we need to have. We're seeing some really interesting international research taking place in this country, and as with all things related to alcohol, we have remarkable experts in this country, many of whom we don't listen to in Canada. Go to an international conference and you'll find that some of the best minds and those most listened to are Canadian. But we typically do not want to talk about this issue. There's a huge taboo, and in my book I call FASD the last taboo. The last taboo where a handful of very, very brave people have taken the microphone and are trying to make a difference, both nationally and internationally. But it is the most stigmatized area of a very stigmatized subject. And how one blows some fresh air and oxygen into this dialogue, into the support that's needed, and certainly support of young women. We saw in 2011 the really remarkable initiative in Canada to have low-risk drinking guidelines that everybody could agree upon, which state very clearly that any more than 10 drinks a week for a woman is not safe, no more than 2 drinks on any one occasion. We also know that binge drinking is on the rise, and binge drinking typically means 6 or more drinks at any one session. And by that, I'm not talking about how we define binge drinking, but I'm saying that the most common pattern in binge drinking is 6 or more. So we really have a troubling situation. You take my alma mater, Queen's University, where bright young women talk about competitive blackout parties, where the winner is the first person to black out and lose consciousness. We all know what's happened in recent years with the exposure of young women on Facebook and social media when they've been compromised and intoxicated. We're in an extreme culture when it comes to drinking, and we've seen some remarkable initiatives. I'm going to cite the one out of the University of Saskatchewan called What's Your CAP, which is a program overseen by Colleen Dell, remarkable woman who, where students are student-driven, starting to talk about, what is your CAP? how much can you drink, should you drink. Great initiatives happening for that younger population across the country, but this is just the tip of the iceberg. And social media and media itself and big alcohol is really fighting the battle hard in terms of exposure. So you have wines with names like Cupcake and Girls Night Out and Mummy Juice and, yes, in the States, Happy Bitch wine and berry flavored vodkas and pink vodkas. And these are not manly drinks. These are focused on women and aimed at women and aimed at to try and get women to drink more. So we have a wrestle in our culturally where there's enormous pressure to drink. There's an enormous sense that if you drink, you will be happy. You will fall in love with the person you're meant to fall in love with. You'll have tons of friends and have great weekends at cottages. And this is a far cry. This media push is a far cry from what the reality is, which is young women waking up and finding out they're pregnant when they didn't expect to be, and waking up to the reality of FASD and dealing with it. And I applaud people like Dorothy who are providing resources, like Jan Lutke and the others in Vancouver are providing conferences and, as I say, blowing some wonderful oxygen into the dialogue and oxygen into communication on the subject and reducing the stigma. I can say that when I wrote my series in the Toronto Star on women and alcohol, which then became the book Drink, I asked each and every woman who, like myself, was an alcoholic, would they rather be known as an alcoholic or a depressive? And each person said they'd rather be known as a depressive. To be a woman who drinks too much in our society is incredibly shaming. And to get sober and to battle addiction is incredibly difficult. And we need to bring a lot more compassion to the table and a lot more understanding and a lot more support. And I applaud people like Holly and Nancy Poole and many, many other soldiers, foot soldiers in this incredible fight in this country to bring the proper form of understanding, appreciation, intelligence, and ingenuity to this dialogue, because it takes an awful lot of resourcefulness to be like a woman, Janet Christie in my book, to be a birth mother who has battled for the best for her son, who has been there and fought the good fight with supporting other mothers and dealing with the basics of helping mothers find housing, find education, finding the right kind of support, and definitely diagnosis. So on a global social level, the good news is that we have some remarkable people gathering together and pushing at the frontiers. The tough news is that if we look globally as well, we have got a very, very troubling push on the part of big alcohol, especially in the third world, but definitely here as well, to try and connect the dots between drinking and success. And it's a fight that we have to speak about, and we have to become a lot more vocal. And I think with the convergence of voices, a lot can be won. I will close by saying we are in Recovery Month. This is a special day for FASD, and it's a special month for recovery. And there are a lot of birth mothers in recovery who are wrestling very, very hard for a better understanding for their children and for what they experience. And I want all of us to be aware that in Recovery Month, we're beginning to celebrate a recovery from addiction. And it's really important, I think, for all of us to look around our communities and see if there's a rally or something you can take part in. So thank you very much.
Thank you, Anne. What a powerful presentation. I mean, that was really, really fantastic. Really brought a lot of lot of the hard issues to the conversation here. So again, my chance to remind everyone to type their questions in. We do have a couple questions so far, but I would like to hear from Gail and maybe get your thoughts. Maybe reflect on what you've just heard before we get to the questions from the audience.
Thanks, Doug. Well, I think what I'm hearing is the power of having the right information and knowledge about FASD and about alcohol use in pregnancy and alcohol use in women. I think dispelling those myths, there's so many myths out there, and we talk about stigma. There's the stigma about bad mothering and blaming and shaming instead of looking at all the other factors why a woman may drink during pregnancy. And so just shifting by giving the right information, hopefully there's going to be a broader and a better understanding of FASD across professionals and I guess the whole public awareness. And recently there was a paper published on stigma through NeuroDevNet, the neuroethics core of NeuroDevNet, led by Dr. Emily Bell. And it really explored the concept of stigma from the mother's perspective, but also stigma from the caregiver's perspective. Many caregivers feel that they get fingers pointed at them because it's bad parenting instead of understanding that it is based on differences in brain function. And then the other person involved is the individual who is living with FASD. And it's almost, you really have to live with a condition to fully understand it. But those of us who've worked in this field, we've benefited from the learnings of people who have been, like Jan Lucky, caregivers of individuals with FASD, and actually have been able to meet many individuals living with FASD to give us that real knowledge. And the myth out there is that there is an inevitable negative life trajectory, that somebody who is born with prenatal exposure to alcohol will go directly to jail. And by all the work that increasing knowledge across systems of care, improved educational system access, preventative mental health, and supporting caregivers to do this really tough work that they're doing, I think there's some optimism that we can improve residency and have better outcomes. So I think knowledge to change the whole perception of FASD.
All right, thank you, Gail. So we do have a few questions coming in. We mentioned, the additional challenges for the birth mothers as opposed to adopted parents. We do have a comment from one of the birth mothers out in the audience. This is from Rachel, and she says, Anne, I listened in with a webinar of you last year and enjoyed it very much. Loves the issues you bring up, and as a birth mother of a child with FASD, it helped her understand her drinking issues as well as allowed her to work with other mothers on their issues with their children. She was able to be candid with them, which she believes may have factored in when she was coordinating an FASD awareness program at the agency she was with at the time. She loved the quote you mentioned earlier. It was very true with the stigma. She is Aboriginal, and as the history of their people has been at the forefront this last couple of years, FASD in the Aboriginal community is huge due to the historical factors. Her son has FASD and ADHD. Sadly, he appears Caucasian, and he is swept under the rug with the just ADHD. She says her son is very vocal and owns the title FASD, but says it's not who he is. He makes her proud every day with his struggles, and he's aware that she had issues, and it wasn't her intention to hurt him. So anything to say to Rachel there?
Well, I mean, I'm fighting tears. That is such a powerful litany of things to be wrestling with, and I'm really grateful to Rachel. Thank you for the support, and I flip it back to you. I flip it back to you for and to Jan, for being as eloquent as she is and is unflinching in terms of guiding me to have a better understanding of the way society looks at this issue. It takes enormous guts to, I think, be a birth mother and to shepherd a young person through society. And I think that there is a constellation of strong women I mentioned Jan Christie, and many of you would know her name, who's in my book and is a birth mother and is so has been so key in helping other moms. And I think this is a sisterhood that is growing in Canada, and one that is obviously really, really important. And it's an international sisterhood. So you have strong women in Scotland and strong women in the UK, and willing to be there. And so I think the strongest thing that I would say as an onlooker is connect. You know, Ian Forster's word, only connect. Connect to others. Get the support you need. Find the sisters in this fight, because they're here in Canada, and it's a growing group.
And Rachel did have a question for Dorothy, and Deborah, feel free to jump in on this. Dorothy, during your presentation, you mentioned focus group meetings with foster parents. Rachel was asking, were there any birth parents in attendance?
You know, we did a project in Alberta. We've done 2 projects around what we call the FASD community of practice. And so we actually did meet not only with foster families, but with kinship care providers. So families were included, because often it was an aunt or an aunt and uncle or a grandparent. So yes, we do meet with families that are caregiving as well. And we also recognize that the need for all caregivers to receive support from each other. So what we've grounded our work in Alberta on really is a really strong training module on FASD that is delivered to all foster parents. That we have our local fetal alcohol networks under our Alberta FASD Cross Ministry Committee that provides support in kind of urban, rural, and remote communities. And we have our PCAP programs, our parent-child assistance programs, based on the work out of the University of Washington and modeled under Dr. Therese Grant's work. So we really believe very strongly that this is, as Anne said, kind of a community, and that we all work together to ensure support for everybody involved. And FASD is an outcome of a lot of things. It's, you know, some of the things that Anne talked about in terms of personal history, personal trauma that women experience. FASD is really being portrayed as a women's health issue. We have a prevention network action team on women's health under the umbrella of the Canada FASD Research Network. So as Anne referred to, we have lots of activity and lots of people, but the voices of birth mothers are really critical. I did my doctoral dissertation on the pathway of becoming a birth mother of a child with fetal alcohol syndrome at the time as a diagnosis, and really examined that phenomenon. And women certainly, women's voices need to be heard in relation to this topic, because they are the experts, and they will teach us what is needed and how to support most effectively.
We had a question from Shannon, who is asking how much of and this is probably for Dorothy and Deborah. She's asking how much of an impact do the physical disabilities caused by alcohol during pregnancy, such as heart defects, etc., have on people living with FASD? She says they see very little information on that topic.
Actually, I think that would be best answered by Dr. Gail Andrew.
Well, probably good. Yes, Dr. Andrew. Any thoughts on that?
Well, I think we tend to forget that every cell developing in fetal life is susceptible to the harmful effects of alcohol exposure, so that other organ systems, if the alcohol exposure happens during that time in fetal development that the heart is developing, you can develop a congenital heart lesion, problems with hearing, vision. Multiple systems we know are involved. And one of the messages I give when I talk to primary health care providers, to people who are looking after even newborn babies and children in general, and adults, always keep that in mind. Look for the other alcohol-related birth defects. We always concentrate on the brain because brain function inevitably hinders you from adapting in life. But if you miss a chronic health problem, then that person has the added burden of a physical health problem as well as dealing with all the challenges. The sleep disorders that Dorothy mentioned are huge, and we see them probably in about 90% of individuals who have prenatal exposure to alcohol. We are just beginning to scratch the surface from a research perspective as why sleep disorders are so common. Where is the problem there? Dental problems. We forget to even look in the mouth sometimes to look for cleft palates and teeth problems. So it is a huge problem, and we need to have the health community really be aware of that. That is part of their job.
Thank you, Dr. Andrew. As I mentioned at the beginning, it's always great to have your expertise added to these panels, even at the last minute. It's great to have you here. Kara had a question for, she says for Dorothy and Ann, but certainly, anyone on the panel, feel free to jump in. She says, around the stigma, what are some of the first steps to combat the stigma? What can we do on a community level?
That's a good question. Just briefly, I will mention that I think what we need to do at a community level is we need to think about prevention as a community activity, that all of us are involved and invested in the health of our children, in the health of our communities. And so really this work is that we're all in this together. And I think knowledge is a key factor in reducing stigma. And, really, from my perspective, children with FASD have disability. And so we need to, and it's interesting because it's one of the most stigmatized disabilities to have, and there's been challenges for people with FASD in receiving disability supports in different jurisdictions. So I think that we need to provide access to services, because we know that the supports offered to children and supports to caregivers, including respite, are very critical factors. So if we support children more effectively, if we support them around particular behaviors, and we really protect them as much as we can across environments where they're at with consistency, structure, routine, that we are actually supporting a whole lot of other things that filter out from that foundational stability of the child and the caregiver, and how they interact and what the caregiver knows, and how that support that is given to the child really can have a lot of benefit, not only for the child but for everybody around them. Ann?
I think there's such a big boogeyman about, I agree with you and everything you said, of a big boogeyman around understanding what this really means. Like everything else in life, when I get up in front of an audience and say this is what an addict looks like, you have a culture that thinks it's that guy down in the beneath the bridge with a brown paper bag. That's what an alcoholic looks like, or the rare drunk driver. But they don't think it looks like a woman who has been vice principal of McGill University or whatever. And similarly, one of the things that has been so remarkable about these Vancouver conferences is I've met a ton of young people with FASD, a ton of people, and understand the wide variety of challenges, to understand and appreciate the wide variety of strengths, and to understand the strengths of the parents involved as well. So, one birth mother told me that she was going to a support group and she found herself to be the only birth mother. All the rest were adopted parents, and she felt like she was at a witch hunt. And that was a long time ago. That was 20 years ago. I hope that we have evolved in that world. I have a severely disabled niece who is disabled with something else, but we live with a disability in our family, and it takes a lot of as I said earlier, blowing some fresh air into the discussion and saying it may not look like what you think it looks like. Diagnosis is key, but understanding is also key as well.
All right, we've got a couple of questions here related to the education system. First, a comment from Blair is saying, children with FASD in the public school system continue to meet with ignorance, and as a professional working with children with FASD, it's continually frustrating dealing with educators who are not educated in FASD. So Blair asks, are educators receiving updated information or workshops in assisting or dealing with their children with FASD? And Rachel is also talking about the curriculum as being a preventative tool, and is there an opportunity to incorporate the curriculum into school health classes? So what's the role of the education system here as far as incorporating it into the curriculum or to educate or training our educators in this area?
I'd like to invite Deb to answer this if possible.
With regards to educators and bringing them into the discussion?
Yes, absolutely.
Well, I think we need to start with our schools of social work and our other professional schools, our nursing schools, our medicine, in education as well, and having a common understanding. FASD is not typically taught in most of the social work settings. I think Dorothy, University of Calgary is probably unique because you're there, but it's not yet a common element across all academic institutions in Canada, and we need to change that because our graduates are coming out and not knowing what FASD is.
Yes, and we teach a course on FASD and child welfare practice, and I had 29 students this summer, and I think we have a responsibility in our human service professions to certainly educate upcoming professionals and graduates how to kind of work practically with some of these very complex disabilities. And I think
if I could just project
sorry,
again.
go ahead.
Here in Alberta, Dr. Jackie Pye, who's the lead of the intervention network with the Canada FASD Research Network, she's with our Department of Educational Psychology, and she's developed a program called the Parachute Program, which goes into schools and gives knowledge to the teachers around what is FASD and how to adapt within the day-to-day educational system to work with those students. So that's one example of a program, and I know Jackie is also leading some specific intervention research on improving math skills, memory skills, so that's work in progress. There's also within Alberta called the RAP program, and it's based on residency, and it's a mentorship model. And again, it goes into the schools by invitation by the school, so it's not widespread. But the RAP coaches work directly with students who have FASD, but also provide general information about FASD to all of the school staff. So there's little pockets, I think, of promising practice, but I echo the fact that trying to get FASD embedded into core curriculum of all professionals is really needed. We've only been successful in getting it embedded into the curriculum of fourth-year pharmacy students here at the University of Alberta, where they receive a lot of information about FASD every year. But I think we have to speak to those within the university. This should be core curriculum because FASD touches all systems of care, and it is a lifespan disability. So we really need to think of it quite broadly. So if there are educators listening and can get that into curriculum, we've got the curriculum developed. We just have to have the invitation.
Yeah, I think that's specifically what Rachel was asking about, and I see Dorothy put in a little chat box that we have as the panelists here about teaching it in high school. I think that's specifically what Rachel was asking about, is incorporating the curriculum into what I assume to be high school health classes. I'm not sure how young you would introduce this, but at least in the curriculum of a high school school health program.
I think it's a brilliant idea. It certainly, we need to start earlier, and I think Anne's argument around that of how much the media and marketing is wooing our youth with regards to this, that they need certainly to be educated. The other point I'd just like to make, and you just touched on it in the last speaker, was the issue of gerontology with FASD. We often think about it as the beginning piece, but there is a whole element of FASD with seniors that we really haven't done much learning about that we need to, and the effect of aging with an FASD brain. So there's a lot we have left to know.
Kara has a question regarding the curriculum and just wondering when it will be, or if it's available in French online.
I can probably answer that. We're just in process now of actually updating. We're going to update the curriculum and make it, put it into what's called an articulate software, where there will be embedded videos, there'll be an evaluative component, it'll be much more interactive. And we, I think Public Health Agency of Canada will be a partner with us in getting that into a French version.
Lynn is, she's got a similar question to the one we just asked. She said she's interested in knowing if there's been any progress from school systems in providing appropriate support for FASD-affected children. I guess she's not really talking about from the prevention perspective, but for children with FASD. But any thoughts on sort of the progress from the school system in providing supports within the school for children with FASD?
It's Deb, and I know of the Winnipeg School Board, and probably many of you do. They are certainly leaders. I think they have 8 FASD classrooms, and we can learn much from them in providing, where the school has really taken a strong leadership role in supporting youth with FASD, children right from grade 1 all the way through to grade 10, and they make significant outcome achievement with those youth and getting them to graduate. So certainly having discussions with our school boards around more specialized FASD services within the school is an important area for us to move on.
And so we've got lots of comments sort of supporting, even these actually came in before we had this conversation about the adults and the elderly with FASD. Lynn also saying that adults affected are vulnerable and wondering about best practices for their care and protection. We sort of touched on that a bit. Any more to add around that as far as adults, the adult piece? I know this is not the adult audience at CAPHC, but any other thoughts on adults with FASD and what we might do in that area?
It's Deb again, and I don't mean to hog it here. One of the things we did for the Public Health Agency of Canada was actually document all the FASD services within each and every province. And so there's actually a PDF in French and in English with all of those services. And then we did an analysis of what that looks like across Canada with a footprint, and to whether or not the services are really aimed at the youth or are they aimed at adults. And for the most part, they're sort of mixed services between youth and adults, although most of the diagnostic services are really aimed at the youth. And so there's a real gap in Canada around trying to get a diagnostic done as an adult. Often from the child welfare perspective, we get a child diagnosed with FASD, and then the parent begins to sort of question some of their behaviors and issues, and will often then seek a diagnostic confirmation if they have FASD, because then there's benefits that they can obtain. But we still are early, I think, in Canada in sort of getting adult services for those with FASD. There are pockets, I think, in Canada that have done way better than the general Canadian landscape.
Mm-hmm. And just to add to that, we've actually done a recent study that we completed at the end of July on the topic of FASD and homelessness, because that really looks at what's happening to adults when they move kind of out of the child welfare system. And, there's lots of concerns. We interviewed 16, kind of a range in age, and people with FASD, as well as we interviewed 30 professionals, and we also looked at the systems of care in Calgary and how many people were identifying to various systems and related to alcohol-related disabilities. Mm-hmm. they are very, this population is very vulnerable in the homeless sector. We know that we have people that are anywhere between 30 to 60 that have a sense they have an alcohol related diagnosis, but they haven't been able to access a diagnosis because of their life circumstances in large part, but also because we do need more resources to diagnose adults. And the Public Health Agency of Canada did a study on that around 2007. We looked at 2011, we looked at the adult caregiving system and what existed for adults. And we do have an adult diagnostic clinic that Dr. Gail Andrews is involved with, but we have a long ways to go with recognizing and supporting the needs of that population, especially when they enter other places like nursing homes and things like that. And so there are many unrecognized people with FASD for adults.
It's Gail here. One of our learnings from our adult clinic is the importance of relationships, positive relationships, because many of these young adults and even 30-year-olds, 40-year-olds coming in have not got anyone in their life who is going to be there to, first of all, support them through the diagnostic process, or then to work with that information after, because diagnosis on its own is a four-letter word, FASD. It needs to lead to positive changes. So individuals who have brain compromise from FASD, they are not going to be able to navigate the system of care that they need to get into appropriate housing, to access health, access mental health and addictions care if they need, and to find employability options within their levels of strength. So it's that we actually were able to give each person coming to the clinic a mentor, somebody who is hired, not as good as a personal relationship, but a mentor who can help guide them through that process of care. The other piece that we're learning from the pediatric adolescent clinic is kids have a bad habit of growing up. And it's that transition chasm, it's a cliff. What do we transition to? There's sort of paperwork that you need to go through for funding, but it's that without a positive relationship, our young adults are going to fall over that cliff. So again, there's gaps. We're learning as we go, but many gaps.
Doug, it's Elaine. Can you hear me?
Yeah, go ahead.
Yeah, I'd love to make a comment or two if I can at this point. And Gail, I think you've just triggered something really, really important. So if I may, and I'll be very quick, I just want to make a comment of how fantastic the webinar is, and thank you to all of our experts who are sharing this morning. To Jan's first comment, actually Anne's first comment, my apologies. One of the first things that I thought about, Anne, listening to your passionate, so very passionate, not presentation, but sharing of your thoughts and experiences, is that, you know, the work that's been done to date collectively, and I'll refer to the work across Canada by so many dedicated experts in this field. CAPHC has been very, very fortunate that we've had the opportunity to work with these experts from coast to coast and with the Public Health Agency of Canada in a KT role, in a knowledge translation role. And, you know, we've talked about screening tools, we've talked about diagnostic guidelines, we've talked about the revision of those guidelines, we've talked about maternal drinking, we've talked about prevention or at least, again, diagnosis of infants through meconium screening, and the list of tools and the how-to, I'm going to refer to it that way, has been a huge emphasis on the work that we have translated over the last 6-7 years. as a collective community, and I commend everybody for that incredibly important work. And what you've made me think about, and it's going to stick in my mind, is from an advocacy perspective, from a so what perspective. We haven't done enough of that, and perhaps haven't dealt with some of the real issues around women's health, around the addictions, and how difficult it is to be an addict. And you raise so many points that I know I'm not articulating this well, but I just put it out there that perhaps this is something that we can collectively think about and address in future virtual events like this one, as well as face-to-face. And then, Gail, your point, and I'd love, Anne, for your comment on that, if you wouldn't mind, and if I could just put out one more point. Gail, your point just now on transition. You're very well aware, of course, of the work that CAPHC is doing in our transition from pediatric to adult care. And this is a huge issue, a challenge for every single child and youth health organization, provider, family, parent, etc. in this country. But we talk more about cerebral palsy. We talk more about developmental of the physical nature. We talk more about mental health in some ways, but that transition and its relationship to FASD is not front and center, and it's huge. And you know, the comment a few minutes ago about the elderly then that move on to nursing homes, I have to tell you that that's a component that is blatantly obvious as a result of this morning's discussion, but certainly not something that is flagged. So I just wonder if I can just, based on the tremendous knowledge that's been shared this morning, if maybe in future direction and planning of work together, we can start thinking about some of those issues, in particular the ones around transition and some of the issues that you raised, Anne.
Well, I'll leap in here. Thank you so much. What a thoughtful response. We live in a there's a wonderful man in Vancouver who told me, Dan Rees, who used the image of a frog pond, where a lot of the frogs are becoming sterile, and others, are developing terrible growths, and everybody says bring in the surgeons and bring in the and bring in the fertility experts, and a wise woman says maybe there's something in the water. I think there's something in the water. We live in a culture. My book Drink looks at the culture of what young women are coping with, and young women are being told that they have to be perfectly thin and perfect at work and perfect at home, and it is no wonder that alcohol is being used as a decompression tool and is being used for all sorts of things. And we need to, there are millions of Canadians living in recovery. There's millions of Canadians dealing with consequences of their drinking. So we need to have a much broader conversation with young women and doctors. I mean, young women have had 3 messages in the past few years: that it's okay to drink when you're pregnant, that it's not okay to drink when you're pregnant, and maybe it's okay to drink when you're pregnant. We have a very confusing situation, thanks to, in part, that 2010 British study, and it's a confounding culture to be a young woman in. It's a confounding culture for all the other reasons. So that's all I have to say.
All right, we were talking before about the education system and what the role would be there. We have a comment that came in from Kelly and a few of her colleagues who are all educational assistants who work with children in their early years. She says it's their experience that there isn't enough resource and support that addresses their students' individual classroom needs. Are there any other resources that you can think of? So we've talked about how do we get this into the schools for people to start educating students and teachers about this. What about those people in the education sector who are interested in starting to make some headway on this issue? What resources, in addition to the curriculum on the Toronto Children's Aid Society website, what other resources might they turn to as Dorothy or Deborah?
Oh, sure. I think that we need advocates to really bring this issue forward in the education system. I think the teachers today have so many things to cope with in the classroom that it is very challenging, I think, to perhaps identify one child who has FASD, and the aids are really, really important in the structure. So the support system needs to be in place to help the child have a good day, really. And if the child has a good day, everybody around them has a good day. So it's really important to advocate for those kind of supports and to, I think, have a little seminar in a school that is about FASD, or take part of the curriculum and review it and see if that makes sense, or go to another resource and enhance what you're learning with some great videos or talks that really highlight some of the challenges and even the specific learning challenges, because what we know about education for children with disabilities is if you provide accommodations to support the learning, that the children do better. So I think we just need to continue to have the voice. We know that there are many educators who have done a really great job of trying to support children, and sometimes children's needs outmatch the resources. So that's where we need to continue to advocate and to consider how resources are delegated to various schools to support children, because it really does take a whole community to support children with FASD. And it does take engagement across a wide variety of sectors. And so children in school are part of a community, and it's really important that we, if a child's in a wheelchair, there's a visible disability. With children with FASD, it's often an invisible disability that is recognized through behavior or other challenges. So we want to minimize those challenges by structuring environments that support success as best we can. So FASD-informed practice is certainly a good pathway to follow.
It's Gail. From the Alberta perspective, we have an inclusionary school system. So unlike Winnipeg, we don't have separate schools for individuals who are living with FASD to go through their whole years of school. We have some preschool models where kids with FASD get a tremendous amount of support around their individual needs and sensory needs, but that only goes up to entering into grade 1. But if we're dealing within the inclusionary system, I think a lot of the right knowledge, understanding FASD, how we can do some different structure within the environment, and have a profile of that individual's learning pattern. We are talking about FASD, but we're still talking about individuals who have their own specific pattern of strengths and challenges. And that's, I think, part of we have a general idea of what to do, but I think each person also needs that individualized approach, which is hard when you're dealing with 30 students in the class. That's the reality. But I think knowledge about FASD is a good starting point for all teachers and teachers' assistants. And perhaps we could invite Jackie Pye to come onto a webinar and bring some of these promising practices forward for discussion.
Yeah, we've got lots of questions and comments related to the education system. Leah is saying, Rachel was asked if any other provinces have classrooms designated for children with FASD. In Manitoba, they have 4 schools with 1 classroom and with 8 children, and that includes high school and even in junior high. So Dr. Angela, that was great talking about the Alberta experience as far as integrated classes. Leah is saying that Frontier School District in Manitoba, talking about resources that might be valuable, Frontier School District in Manitoba has a very good prevention curriculum for grades 5 to 8 called Making the Right Choices, which is mandated in school division policy to be taught in all schools in the district. And you can get that from the library services at Frontier School District in Manitoba. So there's some more resources for people that are interested. Kathleen is talking about the Alberta Learning Guidelines for Teaching Students with FASD, which is a free, downloadable, and useful tool for school and home. Any thoughts on that tool? Gail, you'd probably be the most familiar with that, being from Alberta.
Right. That's through Alberta Education, so it's a government document, and it's got a lot of good practical suggestions for what teachers can do in the classroom, and some information on specific learning disabilities, like the commonest learning disabilities that we see during our clinical assessments is math learning disability, which affects your ability to handle time and money, and reading comprehension, which is a huge disability throughout your life if you can't read all these documents and understand them that you're being given over and over again. So it's a good document. It needs to be, I think, updated as we've learned more about strengths and challenges in FASD.
All right. This question came in from a group in Ottawa for Anne. You mentioned that FASD is color and SES blind. I'm pretty sure that means socioeconomic status, or like blind to a socioeconomic status. Can you speak a bit more about that? Do the studies that you talked about in your presentation support that women of older age and higher socioeconomic status have more or as many children with FASD?
Well, I think that's the million-dollar question. And, you know, I spoke to a school principal who doesn't want to be named, who said that he deals with untold number of kids that are labeled ADHD, he says are not ADHD. This is probably the thorniest and most difficult question, isn't it? How far have we gone in terms of not diagnosing properly? And how widespread is that? And many think it's very widespread. So I can't go further than that. I tried, like the Dickens with my book, to get someone to go on the record more than Jan Lutke did with proof, and I was unable to. So as a journalist, I pushed very, very hard. I pushed all across North America. If you speak to Phil May, if you speak to a woman named Sarah Matson, who's Associate Director of the Center for Behavioral Teratology at San Diego State University, she talks about new tests that are being done, neuropsychological testing, to find out more about children who are not being recognized. But you know, she says having the facial features is not important. The exposure to alcohol is, and whether they show similar behavioral and cognitive features is the essence. And I think we have focused too much on facial features and not focused enough on behavioral and cognitive issues. But if you speak to any number of people at CAMH and beyond, they'll say our greatest shortcomings coming in Canada is diagnosis. We cannot keep up with that, and it's costly. So the now retired Sterling Claren, if you speak to him, if you speak to any number of people, they will say diagnosis is the issue. And you know, there are people on this webinar who know a lot more about it than I do.
It's Gail here. If I can make a comment, because our clinic is running at full capacity, and we simply can't work faster. We've got a year's wait list. But one of the problems with this disability, in order to move forward for a diagnostic assessment, you need confirmed prenatal history of the alcohol exposure during that pregnancy. And that's the big gap.
Yes.
And many of the kids that I see the brain profile through testing, and I can't give an FASD diagnosis because I can't get that confirmed alcohol, or mom is, because of her own guilt, not willing to come forward and confirm that she did drink during the pregnancy. So there's the biggest barrier.
Yes.
Until we have a biological marker that's reliable and valid, we won't be able to do that mass kind of population screening to bring forward those individuals who need a diagnostic assessment workup. So again, speak to the researchers. I know there's a lot of interest in looking at neuroimaging studies. We're not there yet.
It's Deb. One of the things I had Dr. Barbara Fallon do, which did the Canadian incidence study in the Ontario, well, all the provincial incidence studies in 2008, most recently in 2013, was to take a look actually at the FASD families compared to the non-FASD families. And there were some significant differences on a couple of key areas, both child, family, and case. So, I mean, these are the cases that return frequently. So there's four more reopenings. These are the cases that most likely, someone mentioned before, have very poor support. So not only is there drinking occurring, but they're very isolated and there's not a lot of support. There's lots of other issues. There's intellectual disability issues that these families experience. They're more likely involved in court. They're more likely to have a child in care. And so there are flags that I think if we look for them, we can begin to identify them better and begin that process of an earlier assessment. So you're right, we need to ask some of those questions and get the researchers to do the heavy lifting with the analysis around what is different about these families and how can we identify them earlier.
All right, thank you, Dr. Goodman. And just one suggestion, when you're speaking, I can see in my mind you moving out closer or turning your head towards and away from your telephone, so your voice went way up and way down as you were speaking. So just try and speak into the microphone or into your telephone, and we'll be able to hear you a little bit better when you answer.
That's very helpful. Thank you.
Yeah. We've got a number of questions around sort of next steps that I think I'm going to save until the end. We've got a couple other comments before that, but maybe I'll just give everyone a little heads up that that's going to be sort of the question. We've got about 4 minutes before we have to wrap up, but there's a number of questions about, and we've already sort of talked a bit about it. What's our next step? What next steps should we be doing in order to address stigma, in order to raise public awareness, in order to, et cetera, et cetera. So maybe that's what we'll leave our closing comments with from each of our panelists before we sign off. But we also have, before we get to that, but we've got a few other comments and questions about services related to transitioning, children with FASD transitioning to adult services and continuing to receive services, or where do adults get diagnosis or services as adults. Does any, maybe Dr. Andrew or anyone on the panel, any thoughts on that? And once again, going back to these adults or these children that are transitioning into adult services, as far as where they would receive these, in particular, just from your own experience in Alberta, or any thoughts you have across the country?
I think I'm going to go back to one of my earlier comments about positive relationships. Those adolescents who are transitioning to young adulthood, who have a good caregiver, strong relationship, the caregiver can advocate, and there's, again, tons of paperwork needs to be done for the financial support or arranging guardianship, but more also to connect with employability options. We've got a few pockets in Alberta where there's opportunities for post-secondary education, capturing on the strengths of individuals living with FASD in community colleges. But you need a caregiver to help you with all that paperwork and to get you there and to ensure that transportation to the program. So there's a lot of complexities that navigating the system of care, you need that caregiver to do it with you. Housing opportunities, we have some models within the province of housing specific for individuals with FASD. And again, it's under the process of evaluation, looking at, is it effective? Because we need to also respect the autonomy and the individual rights of that person. That to give them, we want to protect them from victimization and being drawn into that life of homelessness and despair. But we have to respect their rights. So it's not so easy. I think over the next couple of years with some evaluation of these programs, we'll get a better sense. But we also need to educate the people on the receiving end. pediatricians in the healthcare system, we understand FASD. What about the people in the adult health system? My biggest barrier that I've seen is the adult mental health system. I've had many young people simply not receive the support in the adult mental health system that they need. They've received it up till that point. So again, changing knowledge and changing the systems of support, that's really important. The ones who are most successful have that caregiver who is the advocate, who, you know, like the dog at the bone, doesn't give up, keeps going back and helping their young adult.
From the Yukon has commented that in the Yukon they have a dedicated adult diagnostic team and a research study happening at their correctional facility, which involves an FASD evaluation. Diagnosis is difficult due to lack of confirmation of alcohol consumption during pregnancy, which you commented on earlier, but that's sort of an unfortunate reality of FASD with the adult population, is that a lot of the work is being done in the correctional facilities just because of the nature of the disorder.
Well, and often the mothers are deceased. In some of the earlier research by Claren and Astley, when they went back to find birth mothers, they discovered that at least 40% had died. And so we really have to recognize the challenges that come with that. This is a public health issue. FASD is a public health issue. It may be preventable by abstention from alcohol during pregnancy, which is why education is absolutely critical at all levels. But we can also say there's a lot of other social problems that are preventable, such as domestic violence, such as poverty. So the message that FASD is 100% preventable needs to be challenged in the sense that it is, but people have real lives. And so if we can work towards prevention from a holistic perspective and grounded in the reality of the experiences of many women and historical trauma and all the things that result in FASD as an outcome, it's just it's a message. FASD as a diagnosis is a message to look back, to support families, to look at how we can do things differently. So I think that we are doing great work. We have a long ways to go.
All right, so we're just about out of time. Two quick questions. First one for Deborah, for Dorothy. Has the caregiver's curriculum been pilot tested and evaluated?
What we did was we actually used consultants for that process, so people like Jan Lutke, and so we didn't do a formal pilot. We certainly used a lot of rigor and relied on current research, which we've really identified within the curriculum. So we hope that that would be something that we could do going forward, because we did a lot of work in a fairly short time frame, even though it was 3 years, the last year dedicated to the curriculum. We wanted a resource people could use, and the potential to do other pilot testing certainly exists.
All right. And one for possibly, I guess this one should probably go to Dr. Andrews, since I know the new diagnostic guidelines are something she's very interested in. And you commented on this issue of not being able to confirm the diagnosis if you can't demonstrate a history of alcohol consumption during pregnancy. Will the new diagnostic guidelines, is there anything in the new diagnostic guidelines that will help individuals possibly affected as opposed to definitely affected, sort of addressing that question in the new diagnostic guidelines?
There's still going to be the need for the confirmed history of prenatal exposure to alcohol, and maybe what I can just reflect my particular practice. If I see somebody who has that profile and I can't get the confirmed alcohol history, I cannot assign a diagnosis, but I write a report indicating that this individual's profile is one of organic brain damage and dysfunction, and the supports that one would apply to somebody with an FASD diagnosis should apply to this individual. So I don't give a diagnosis unless we have the only one biomarker, if we have the complete facial dysmorphology. That's the one category that if you have the classical face of fetal alcohol syndrome and significant impairment, you can do a diagnosis of FAS without having the confirmed alcohol. So that's still I think that's the sticking point in all of the guidelines, and not just the Canadian, but the ones used in the States and the one and in Australia as well.
Yeah. All right. We did have a couple just quick comments before we wrap up. Rachel did say that when we're talking about resources for educators or anyone who wants to get more information into their schools or their clinics or settings of care, Healthy Child Manitoba has some great resources that can be found on the Healthy Child Manitoba website. Blair commented that in Prince Edward Island they have a child development team at Lennox Island First Nations where they have educators, health center staff, mental health professionals that all work together as a team to approach and tackle cases in their community. So that's all we have. We managed to get through all the questions. So I'll go back to that question that I mentioned at the beginning where we'll maybe just go around and hear from Anne, Gail, Dorothy, Deborah. What are the next steps that people can sort of walk away from this presentation with to address the stigma that we were talking about, address the lack of public awareness, and all of those issues? What can we do? Maybe we'll start with Anne, and we'll go around the table and just hear some final closing comments and focus on those next steps.
Well, first of all, I just quickly applaud everybody this morning for being part of this. I think this is part of the next steps. I'll do something quite tangential. You know, in my research from my book, the number one predictor on whether a woman is going to drink is whether she's been sexually assaulted or abused by a parent or by someone when she was a child. And I like the fact that we've connected the dots this morning between how a person lives, poverty, challenges related to housing, etc. I think we need to be thinking holistically and organically about marketing and the culture we live in. So thank you for opening the dialogue.
And it's Dorothy. I think what makes this presentation unique is that we've not only looked at FASD and caregiving, but we've also looked at addictions and women's health issues and other systematic issues that are really important. So I think knowledge on addictions is also critical in understanding FASD, and they don't often get paired. So I think that's a really helpful direction as well.
It's Deb, and one of our hopes and wishes and dreams with this is really the access of information. We wanted an up-to-date, evidence-informed caregiver curriculum that people could access 24/7 and that didn't cost anything. And I think the way going forward is to continue to make sure that people have access to all the information and that this, FASD, we can help make it better. We can help the youth. We can help the adults. There's interventions that work. And that we need to get that information out there and accessible to people. And I just wanted to call out a thank you to PHAC for their amazing support on this topic. So, thank you.
All right. And Dr. Andrew, one final closing comment from you.
Well, I'm going to read the final sentence from Dr. Bell's paper on stigma, and I'd be happy to share that link to get this article. But our concluding comment was increasing public awareness about FASD and promoting behavioral change through campaigns directed at reducing drinking during pregnancy requires stakeholder engagement to develop effective yet ethically and culturally sensitive messaging and policies. So again, that right knowledge, get the right information out there to dispel the myths, and that will help the stigma go away.
Thank you. What a great way to end this webinar. So thank you very much to our presenters and Dowsett Johnston, Dr. Deborah Goodman, Dr. Dorothy Badry, and Dr. Gail Andrew. And I'll include Dr. Andrew as one of our panelists as opposed to my co-host because he made such a great job of contributing some real expertise here. And I'd certainly echo Dr. Goodman's thanks to the Public Health Agency of Canada and to Holly McKay and her colleagues at the FASD initiative at the Public Health Agency of Canada. It's their contributions and support and leadership that have made all of the work that we do at CAPHC related to fetal alcohol spectrum disorder and a lot of work across the country that others are doing. They make it all possible. So I really want to show our appreciation for our colleagues at the Public Health Agency of Canada. So we're going to wrap it up here. I just want to say that we do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great when you can watch live, as these questions and comments, as you can see today, really enrich the discussion. But when you can't watch live, you can always catch the recordings that we make of these sessions, and we always make those available after the fact on the Knowledge Exchange Network. Next week, on September 16th, we'll hear once again from some of our colleagues from the interfacility transport world, where we'll be talking about an innovative approach to using technology to manage patients in remote communities as an alternative to transporting infants. And we'll be hearing infants and children who may be better served by remaining in their communities. And we'll be hearing from Dr. Tanya Holt at the Royal University Hospital in Saskatoon, and Rachel Johnston, who's a nurse practitioner working in Pelican Narrows, Saskatchewan, and they'll be talking about their experiences using, as a team, using these innovative technologies. Following that, we'll be hearing from our colleagues at the Holland Bloorview Rehabilitation Hospital, where they'll be talking about their chronic pain assessment toolbox for children with disabilities. So our webinars on children's pain are always very popular, so I'm sure all of our colleagues in the pain community will be signing up for that one, and we'll be hearing from Christine Providenza and Ashley Townley. We'll be talking about their experience in developing this toolbox for children with disabilities. So it's great if you can join us next week, as we do have some great sessions coming up, and if you can't, always check the Knowledge Exchange Network for those recordings. So thanks again to everyone for coming, and we hope to see you back here next week. Bye, everyone.
Bye.